So Shiva and Biva are new procedures that goes along with IVA. This is a complex procedure that we must learn in a training with proctors. It's not easy to use. And please. And then we try to fix complex aneurysms with these techniques. The first one to do the fenestratic graft was an Australian surgeon, very well known from most of us, Michael Lawrence Brown from Perth. He's been working a lot and is still working and giving an idea to people like Ramon and Patrice Matwipi in Perth. There is a significant increase of this use of technique over time since 1997. But you need a very precise, dedicated planning software in order to work in this kind of problem. You need to design the graft, design from a sizing, very precise sizing, and there is a variety of lengths, and this takes some time to get delivered to your clinic or hospital. I would like to give a word to Matt Thompson. He was one of the first one to use this kind of technique. Matt is now in the commercial business, but we like him very much. He did a lot, and he was one of the first European to work in this field. Thank you, Matt. And he compared mortality with open population compared with fever. It was quite similar, and he validates this kind of techniques to all of us. But the initial commentary were that fever can be safe. Longer follow-up was required, need for standard classification, what is going to be done, and a randomized controlled trial should be organized. A word on Stéphane Hollon, one leader, key opinion leader with Matt at the time. He was a precursor in that kind of techniques. Thank you. And he did a French multi-center experience, and this was quite good. Target vessel, as the previous speaker told, completion angiography. They found thrombosis in 5 target vessels, which is important to know and to treat. The early results were not so bad, and some dialysis, because the length of the operation and contrast media problem. Follow-up was acceptable, and you see the survival rate of this previous and initial publication. There was a shrink rate of the aneurysm, and the initial conclusion of the study was high-risk patient, that was a population. There is a learning curve, so this kind of technique have to be reserved to a center of excellence. The technique is reproducible, and there is quite a homogeneity of literature result. Is it a solution for short neck? We know that it's possible. Look to this type 4 TAAA, and look, this is honestly a complex procedure because you need many catheterization and many things to do on the patient. You can't do that by yourself. You need several assistants to help you for this kind of result. The prosthetic branch are customized. They can be shipped to you. This is the final result of such a user graft. And you need to draw your aneurysm for all the people working with you. everybody has to know what is going to be done. This is an angiography control. Dr. Gustavo Dorich was a very good practitioner in this kind of technique. He moved from Mayo Clinic to Houston. Nowadays, we met him during the Frankvis meeting, and he knows exactly what to do, tips and tricks from him, and we have to consult him. This is the manner to put the patient on the table. You see there is some axillary access and several people working along the patient. Be careful to spinal cord ischemia, and we need a prevention to keep a pressure, blood pressure high, do drainage, cerebral fluid drainage, go in intensive care unit, and preservation of flow in every cases. Dr. Rambo is a little bit critic on this kind of technique, and he knows that there is some other option for juxtarenal reconstruction. Everybody is free of his way of thinking. In conclusion, this is an innovative technique in progression. There is competition with open surgery, but open surgery is a very, very heavy things to do with sometimes some complication. Some longer term results are required, and probably there will be a broaden of indication in highly specialized center with a collaborative team. The question is the price and the reimbursement of this kind of graft, and the length of time that you have to get ready the graft to your hospital for your patient before complication or dissection or what you do. Thank you for your attention.
That was wonderful, Jacques. And I mean, I like you find that fenestrated EVAR is a great thing for the patient, but it's a very complicated treatment to plan, and then particularly to do. It's finicky, it takes a long time. One thing that I was curious about your slides, you were thinking maybe a randomized controlled trial might prove whether FEVAR should be done versus open surgery. Don't you think that time has passed now, Jacques? Because there are very few centers who are doing a lot of open surgery in these complicated cases. And there are very few centers also who are doing a lot of fenestrated EVARs. So how could you really run a randomized controlled trial where there is a great lack of experience, particularly nowadays in open surgery for perirenal aneurysms? Don't you foresee that that's a problem in trying to prove whether this works or not?
Just a note about yourself. You could be one of these because you practice open, as the people must know. There is a question of the younger generation. They don't know how to do open. They are losing the way to treat traditional case. On the other hand, we are very few center to do this kind of technique because you have to be a center of excellence, very specialized, with a lot of people working for you. So this is a question, and I'm afraid that some people will move on simpler technique in order to do something else like stem cell technology, which is on the way. And randomized trial with a big center like Houston, like your center, like Paris former Kiefer Center in Pitié-la-Salpêtrière, and the people from Nuremberg, from Jacob, and so on in Amsterdam. They will probably help us to do far away. But I am very afraid of the price of the graft. this is something like $50,000 a graft, and who is going to pay for that, especially in the third countries and third world countries? What is your opinion, Donald?
It is a problem over here. It's less than that, by the way. It's well, I looked at the last couple of years, and it was with the Terumo aortic graft a set fee of about 15,000. But again, another thing you have commented, a problem is that it takes a few weeks from initially planning to be able to do the case, and that's a big issue, I think, for the urgent patients. It was a lovely talk, Jacques. I am very conscious for Dr. Khanna that the session is a little behind time, and I would ask his opinion as to how much time there is for discussion. Dr. Khanna, what would you like to do? Because it's been a great session from history and difficult cases, surveillance, and the message from Dr. Vieth that ruptured aneurysms are best treated by endovascular. What would you like to do, Dr. Khanna, regarding
I think we have Dr. Sani already on board, so we may have another 5 minutes, and if Dr. Sani permits. And one of my observation here with fenestrated grafts and branch grafts was, I mean, today the technology is advancing, and we do, you know, physician modified grafts and do these, you know. The thing is, what we find very useful is a good planning, and if we have a capability of image fusion in our cath lab, an image overlay in our cath lab, it actually helps us to cannulate and sort of position the fenestrations which are, you know, aligned to the vessels, you know, coaxial to the vessel. That helps us a lot more than anything else, and this is a new technology which actually is going to be very useful in terms of imaging in cath lab. And if we can integrate our CT machines and I mean CT images with our cath lab images, not only that it saves times, it also saves the contrast, and it leads to much better you know, co-alignment of the fenestrations to the vessels.
Il y a le monde entier là. I agree with you, Dr. Khanna.
So, Dr. Reed, you can carry on with the discussion for another 4 or 5 minutes, and then we move on to the next session.
Happily.
Also, I would have a small request. I think we would want you very much in the Ironman session, and if Dr. Busquet can also join as judges.
At what
time is it?
It was at 4 o'clock Indian time, but we are running a little late, so maybe just after this session is the Ironman.
I will be with you.
Good.
After the next session.
If there's one, I'm not keen to delay your congress with prolonged discussion, but I think if there was one thing I would like to comment on, it's of the value in treating patients who come in with a ruptured aortic aneurysm using endovascular. I think it's the most fantastic thing for the patient. The difficulty has been in organizing hospitals, not only to have a team on call every night and day to be able to do this, but also taking the patient through the hospital to get the CT scan with no delay to get into the operating room and be able to do this. But I do think that was a lovely presentation from Dr. Vieth to point out that it is in the hands of those who are doing it a far, far safer thing for the patient than open surgery nowadays. And I think that's a very important message from this session.
Thank you, Donald. You're right.
Is there anything else from the session that you, particularly Jacques or Dr. Khanna, felt was an important one?
I would like to advise the younger generation to be prudent with very complex cases. It's better to save the patient and treat it differently than let it die in dialysis, or because the renal complications are very, very frequent. So prudency and training and advice from the senior surgeon, please, for the youngest generation. It's my advice.
Good advice. Good advice.
So if there are no other questions, Dr. Reed, can we wind up this session?
I
and
think
start
that
the
would
next
be
one?
wonderful. Thank you very much for asking us to do this, and we'll see you in the Ironman session soon.
Thank you
everybody.
very much. Thank you,
very
Dr.
much.
Reed, Dr. Busquet, Dr. Tulio Navarro, Dr. Michel,
Thank you all. Thank you.
Thank you.
and Dr. Saroj Das.